Right. Okay, this is the oral scenario, end of PC3.
You hear my stepfather sneezing in the back?
I just hear noise. I can't hear exactly what it is.
Yeah, that's him sneezing. He sneezes very loud and very goofy. I apologize for that, Mr. Garrett. All right, that works. Come here.
It's the floof.
Yes, gotta have the cat for good luck. Or you can go. You can be free.
I don't want mine around because he stunk up his litter box. But if Mr. Garrett wants to see my Velcro murder mittens, as Peyton so calls him, I will get him. I will be right back.
But since we started seeing cats.
This is mine. Say hi.
All right, let's get serious.
Okay. After you've seen cats,
Yes.
you stink. You want to go first, or you want me to pose you mine first?
Do you have an iPhone?
I do.
Have Siri flip a coin.
Siri can flip a coin.
Yeah, you never knew that? Yeah. Okay, so is the cat thinking you up too?
I don't know. Maybe it's him. Okay. Hey, Siri. Oh, Siri's not going to work. Flip a coin. Tails.
We still haven't decided who it was.
I didn't know. I just want to see if she could do it. Okay, so do you want heads or tails?
I'll take it.
No, do you want heads or tails? We'll flip again.
Yeah. You want to flip again?
Yeah, heads or tails.
I'll pick tails.
All right, I've got heads. Flip again. It's heads this time. All right.
Oh,
I'll give you mine first.
All right.
Okay, chief complaint. Patient's having chest pain, thinks she pulled a muscle. No.
Wait, are we not going to start this like an actual scene?
There's the oral scenario. I'm sorry, I was on the wrong page. Okay, the oral scenario. You are a paramedic on a transporting paramedic unit. You are working with a paramedic partner in a rural EMS system. You are 25 minutes from a level 4, 45 minutes from a level 2, and 1 hour from a level 1. At 13:30, you are dispatched to a residence for a woman with chest pain. It is a cool, overcast fall day with a temperature of 62 degrees Fahrenheit. The husband of the patient and their 2 dogs meet you at the door.
Can you repeat the hospitals again? So you said I have an hour hospital way.
From a level 1. So
Level 1.
say you're an hour from OU.
Okay, so let's say, okay, so that one will be OU.
And you're 45 minutes from a level 2. Would probably be, I guess, Southwest, maybe. So level 2. I didn't
For
get
me,
level 3 on there, did I?
For Wadley's, probably it'll be a 45 minutes, so we'll go with that. What was the last one?
You are 25 minutes from a level 4.
This is the community hospital.
Yeah.
All right.
And
So
your,
I was,
oh, sorry, and your level 3 would be 10 minutes away.
this will be
We're gonna say Porter.
Porter. Okay.
We'll say, yeah, we'll say Porter because it's about, just say Helplex. I'm sorry, not Porter. It's a little bit longer to get into down.
So Helplex.
I mean, they're both the same system, both a level 3.
Yeah. All right. So I arrived on scene and I was greeted by the family. You said the family was the husband and the dogs and children?
Just the 2 dogs and the husband.
The dogs and the husband. Okay. All right. So of course, starting the scene now, I'm gonna start with my big fives. So scene safety. So it's my scene
Safe.
safety. We see let's see, well, that's exaggeration, but let's say, are the dogs threatening? Are they
No,
barking at me? Are they aggressive?
they're overly friendly and they want attention.
Okay, so they're big floofs. Okay, good. That's the best part. Okay. So husband is not aggressive either. I imagine husband appears formal.
He's concerned for his
Just
wife.
very concerned. Okay. Number of patients, just one.
Just one.
Okay. Chief complaint. You said it was shortness of breath?
Chest pain.
Chest pain. Okay, yeah, I wrote that down. Okay. I'll consider C-spine if patient fell or hit her neck or she's complaining of neck pain. And I'll consider additional resources if there's any gas leak or anything like that or something. This
You do
cannot be
have
our
local fire department on scene.
local fire department. Cool. All right, I will ask the husband to please guide us to where his wife is located in the house.
Okay. So the front door is inaccessible by cot. The back door, you can get the cot through the back garden gate, but the gate's hard to open all the way. As you make entry into the back door, the kitchen is the first room you enter, and the living room is just through the kitchen. The living room is where the patient's sitting in a recliner, and a way to get her out. The easiest way to get her out would be out of the backslided doors.
Backside doors.
The sliding glass doors.
Okay. Give me 1 second. Sorry, cat started meowing. He's gonna keep distracting me. He keeps meowing at the door. Yeah, he wanted to leave the room. So you said that the back door entrance is the only entrance. Doors can't open completely. I entered, and the entrance from the back, apart from the 2 doors, from the doors that can't open, is a sliding door.
Yeah, so the back door that goes through the kitchen is too narrow to fit the cot through, but you can get the cot through the sliding glass doors if you need to.
Okay, now I understand my scene. All right. So as I walk in front of the patient, see the patient, what are my initial impressions? How does the patient look like?
She greets you, she welcomes you in and says hi. I don't know why my husband even called you. He's just making a big deal out of nothing. She's a little pale. She is having chest pain. She says, I went to pick up my dog and my chest started hurting. I sat down. It didn't get any better. So my husband gave me a nitro. We waited for a few minutes. It still hasn't gotten better. So he gave me another one. Didn't get any better. And I had another one. And then finally decided I should probably call you but I really don't think anything's wrong.
Okay, at this moment, I will ask for my partner to please start from 4 leads to 12 leads. I want to take a quick blood pressure. I want to take a quick SpO2, heart rate, and oxygen levels. So she said she is a little pale, so she is having oxygenation issues. So I'll probably go in ahead and start 15-liter non-rebreather.
So do you want her vital signs?
Yes.
Her blood pressure 78/49. Her pulse is 47. Respirations
Mm.
are 14. She is 92% on room air. Her temperature is 98.2. And she rates her pain 8 of 10 after 3 nitro in 1 hour.
Okay. As of course, as they're putting on the 4 leads and 12 leads, which will take a while, I will, of course, start talking to the patient and getting some history and getting some more information. So when did the pain started? When did it start to occur? As she picked up the dog and when
So about 2 hours ago,
2 hours ago?
or I'm sorry, not 2 hours ago, started an hour ago when she picked up the dog.
Okay. Is she prescribed any other medications apart from nitro?
She just has the nitro and everything else is just vitamins.
Okay. What the what kind of cardiac history does she have? Does she have
She
blood-
thinks
high
it's
blood pressure?
something like, she says it's just like unstable angina. So she just has this chest pain. She doesn't know why. And the doctor gave her this and told her if she has chest pain, it doesn't go away with rest, to take those.
Okay. Sorry, I'm taking a while trying to write all this down.
It's okay.
Okay, so SpO2, you said it was 97% on room air, or is that with me giving her oxygen?
92% on room air.
92%. Okay. Did it get better when giving her oxygen?
Yes.
Okay. How much did it go up?
It improved to 99%.
99. Okay. All right.
Yes. Okay.
That's my train of thought. Trying to think through my sample and OPQRST again. So we got the onset, the provocation. Oh man, it's been a while since I went through the thing. So she said the quality. The quality, she says, is rated 8 out of 10.
Severity is 8 out of 10. Quality, she says, is like a pulling in her chest. It doesn't go anywhere, but she says there is some tingling in her left arm. Like not a lot, but just feels a little odd.
Okay. PQRS, QRS. So severity was 1 out of 10, 8 out of 10. What's R?
Radiation.
Oh, yeah. She already did give you the radiation because she said it goes off of it.
It doesn't. She said it doesn't go anywhere, but there's tingling in her left arm. When you do your physical assessment on her, you can't reproduce the pain when you palpate her chest.
So there's referred pain. Okay. By this time of my assessment, I imagine my partner has already got the 4 leads and 12 leads on. what do I see on my initial like two lead on the monitor?
Do you want the 12? I don't have the 4 lead.
Oh.
I just have a 12 lead.
Does it, tell me, how does it look on the 12 lead? Does it look normal?
Do you want to see it?
Sure, just give it to me.
All right, hold on. How do I do this again? Yeah, that right there.
Well, ma'am, so we're gonna put these two patches. This is just more to see your heart better. Of course, I can't force you to go to the hospital, so, but we want to take you. Will you want to go with us?
I mean, do you really think I need to go? I think
Yes.
fine.
Yes, you need to go with us?
Well, I mean, if I have
What-
dogs, like I have dogs that have to be taken care of, and who's gonna feed my dogs? I mean, they have to have their cuddles every day at 11, and
Your husband will probably take care of that for you. What I'm seeing right now in the monitor, there's a possible heart attack going on. We will have to take you to the hospital.
are you sure?
Yes,
I
ma'am.
mean, you look, I'm not trying to be offensive, but you look a little young for this job. I mean, do you sure?
Yes, ma'am.
I think I would know if I was having a heart attack.
There is strong evidence. Some heart attacks, of course, don't appear as your straight up signs and symptoms that you can see from chest pain to go into left pain or even jaw pain. Some heart attacks can be very subtle. And from what we can see for a 12 lead, they can tell us of your heart rhythm. And from what it looks like, there's severe depressions. So there is an infarction going on. And we need to take you to.
I have no idea what that means. What is the depressions? Now
Oh.
I'm confused. I don't know what that means.
So I'll I dig myself into this one. Dang it. All right. So I can go ahead and show her the 12 lead. I'll show her what I'm pointing at. I'll tell her like these little things we call depressions are like a little dip on this thing. That's a very bad news.
Okay. Okay. I think I'll go. You look serious, like you may know something, but I promise I feel fine. I think this is all for nothing, but I'll go if it makes you feel better.
Okay. All right. So we'll load her onto the cot. She goes in safely, or oh no, wait, yeah, you said the cot could fit, right?
It will through the sliding glass door.
Okay. So we'll bring the cot to the sliding door. We'll bring it as close to her as possible. I'm not gonna have her stand up and walk or do stuff. We will actually, if she, of course, with patient modesty and with careful handling, we'll help her and assist her onto the cot.
Okay.
Okay. So we have her in the cot. We will start moving her into the ambulance.
Okay.
Okay. In the ambulance, I will start an IV on our right AC, 20 gauge.
Do you want a 20 gauge?
You're making me question myself. Okay, 18 gauge.
Okay.
I'm trying to remember my STEMI protocols. Well, at this point, you'll have two, right? You'll start 2 IVs. fluid resuscitation. I can't ask you. This is an oral scenario. Never mind.
But I can ask you this. If you think you have an active STEMI going on, an active heart attack, would you want one IV or would you want two?
I want two
Would you
IVs.
want large bore or would you want small bore?
I want large bores.
Okay.
Yes, I'll go with two IVs, 18 gauge on the right AC, another 18 gauge on the left AC.
Okay.
I will start with 10 mil back, not 10 mil, 10 mil. Wow, a 10 mil bag. What about 1,000 mil bag? I'll have it wide open.
Okay. So KVO.
Yeah, I'll have them wide open. At this point, I will administer aspirin to the patient.
Okay.
I will administer 320, 26. What's it? Those 126 milligram. I'm starting to doubt myself. God dang it. Yeah, 300. Okay, 325 milligrams of aspirin. Yes.
Okay. Done.
Okay.
So
Of course, through all this, I'll be explaining to the patient, okay, I'm going to start IVs. I'm going to explain the procedure. I'll tell her why. I'll also point out to her it's because her blood pressure is low. Fluids will actually help her get that up. It'll probably help a little bit more for her perfusing. For the aspirin, of course, to stop those platelet. What's the word? Aggregation. What's the platelet aggregation? Yeah. So the clots cannot form around her heart or anywhere else around the body.
It's platelet aggregation, right?
Yes. And so it was the aspirin, of course. The situation with them giving her nitro is the part that kind of worries me the most.
How so?
Because it could be reducing her preload.
Okay.
Yes.
So quick question, do you want to know anything else on her sample?
Signs and symptoms. Allergies. Does she have allergies?
Yes, she is allergic to latex. She's allergic to shellfish and she's allergic to iodine. Quick question, not related this is latex gloves. Yes. They're nitrile. We keep nitrile on the trucks.
Okay.
Latex are usually only reserved for sterile procedures in the hospital.
Okay, good.
We have them. You should have some sterile gloves for your surgical crite kits because it's technically a surgical procedure, sort of. But yes, allergic to latex. But here's a freebie for you. She's allergic to shellfish. Why is that important?
She's allergic to shellfish?
Yes. Why would shellfish allergy be important to you as a provider?
Is it because of the content? Do we have something in our medications or so that provides contents from shellfish?
We don't. However, the hospital, if they want to do a CT on her, they can't give her contrast because it has iodine in it. Shellfish has iodine.
Okay.
So I get asked all the time when I'm going through my medications on my patients and I get to the allergies, I ask them specifically if they're allergic to shellfish or iodine. And my medics are always like, why do you ask that question? It's not important to us. It is because I need to be able to tell the hospital so they won't accidentally give them contrast.
gonna keep that. I'm gonna highlight this. That's very, very interesting. I'll
That's a
keep that.
freebie for you.
Yeah, I want to read. I want to research more on that. That's awesome. So you said it was shellfish. You said it was latex. What else was she allergic to?
Iodine.
The iodine. Okay, so a shellfish and iodine are kind of related together, so that explains. Okay, medication. What medications was she taking? Apart from the nitro, she said she didn't have anything else.
Just vitamins.
Just the vitamins.
Multivitamin, rosehip oil, and turmeric.
Okay. What's the last thing that you have to eat, ma'am?
She had lunch at 11 o'clock this morning.
Does she remember what it was?
It was a sandwich with chips.
Sandwich. Okay. Okay. Yeah, so I think I'll go with that. I think I got nothing else from the sample. Of course, event leading up to this, she was pretty much trying to pick her up her dog.
Picking up her dog.
Yeah.
Now.
Okay, so at this point, of course, I'll have we'll just start heading code 3 to Norman Healthplex.
Okay. As you are driving code 3.
Oh, here we go.
Just remember, you're my friend. Just remember that, okay?
Yeah, yeah, I know. As your friend, you want me to go to the worst to prepare me. Let's do this.
As you're constantly reassessing your patient, you look at the monitor and you see that she's in VFib. And the minute you notice that she's in VFib, she's now completely unresponsive. So
she went unresponsive. Okay.
VFib, there you go.
Okay, what's the heart? Okay, what is the heart rate? So I'm gonna palpate. So is there a pulse?
No, she's in VFib.
Okay, so it was okay, so there's no pulse.
A witness arrest.
The witness arrest, no pulse. I'm gonna immediately shock for. Okay, first I'm gonna start CPR. Oh God, wait, am I the only one? Am I the only one behind the truck?
Did you have a firefighter get on the truck with you just because you thought you might need him?
I think I did. Didn't I?
Or have we left yet? You said you wanted to go code 3.
Oh yeah, no, we have. Okay, no, we haven't left it. Okay, Samia Grace, I'm taking 2 firefighters. So, Schmucko and Schmucko over there, come with me.
Okay, and what do you want these firefighters to do?
I want one starting CPR, the other one to please start BBMing the patient.
Got it.
Okay. All right. So you said no pulse. It was a witness cardiac arrest.
Yep.
I'm going to immediately shock. I'm going to start with. So since it's a defibrillation shock, I'm going to start with 200 joules.
Good.
Okay. So charging, completely charged. All right, everyone clear. No one touching the patient. Clear. All right.
Clear.
Shock delivered.
Okay. Shock's been delivered. Now what?
Okay. I'm going to tell all the firefighters to please continue CPR. Okay. So what do I see now on the monitor?
Well, all you see is the movement from the CPR. You're not going to see anything else. It's just picking up them doing chest compressions.
So do I still see VFib?
Or do you want, are you talking about it? Is it the 2-minute, you want a pulse check, rhythm check? Is that what you're asking for?
Oh, so we're following the time, or are we actually like timing this, or we're doing this more accelerated?
I mean, we're going to do it accelerated, but are you calling for a pulse check, rhythm check?
Okay, yeah. Okay, so yeah, after the shock, I'm going to administer 1 milligram of epinephrine.
Okay. What concentration?
1 to 10,000.
Okay.
Yeah.
So, and now what do you want?
So I guess after 2 minutes passing. Yeah, because you administer shock, then you administer epi. Now I guess now we move. Okay, now 2 minutes have passed. I'm going to temporarily seed CPR and have a pulse check and rhythm check. What do I see?
Okay, same thing. Still in
Same thing.
VFib.
Till VFib. Okay, I will tell the firefighters to please continue CPR. I will now charge the monitor again,
Okay, charging
and I will charge it to 225 joules.
225.
225, yes.
All right.
So to give another dose of electricity. So yeah, we're charging. It's completely charged. Okay, everyone clear?
Clear.
Okay, shock delivered.
Shock delivered.
Okay, I'm gonna have them to please continue CPR.
Okay.
At this point, I will move to where the firefighter is at. The firefighter who is BVMing the patient. I'm gonna have him attach oxygen to pre-oxygenate the patient so I can intubate.
Okay. So how much oxygen do you want?
I'm gonna go with 100% oxygen, 15 liter.
Okay, 15 liters.
Yeah. So imagine at this point, patient is pre-oxygenated. So
Want anything else to pre-oxygenate them?
Anything else? OPA?
At my service, we have the BVM going on 15 liters and we put nasal cannula on them at 15 liters.
Oh, really?
Mm-hmm.
I think my protocol is just the BVM for McLean Grady.
Is it? I don't know what your protocols are, but that's what ours are. But so you've got your 15 liters going, he's bagging, you've got good chest rise and fall, you're getting up, he's getting the oxygen up, and you're going to build that reserve.
So the ET tube went in perfectly?
I don't know. You haven't said anything about ET tube?
No, it's not, you were saying chest rise and fall. So because I still haven't said, okay. So at this point, patient is pre-oxygenated, so I'm going to begin procedures for intubation. So I intubate the patient.
Mm-hmm.
Right, I finish intubation. I inflate the cuff. I'm gonna proceed the firefighter to start BVM again, and I'm going to escalate the lungs. Do I hear? Do I hear wind going through the lungs?
You have lung sounds on both sides. You do not hear anything in the gastric area, in the stomach.
Okay, how's my capno?
You haven't asked for capno yet.
Oh yeah. So I'm gonna place a capno as with the ET tube.
Okay. Capno is at 15.
It's at 15. Okay, so there's adequate CPR.
Mm-hmm.
Okay. All right. So
what size tube did you put in?
It's an adult patient, so I think it's an 8.5.
How big is she?
You got me. Dang it.
8.5 is a pretty big tube. The largest is I think the largest might be a 10. The largest we carry is a 9.
I did not ask for patient height or weight.
She's 197 pounds.
197 pounds.
Mm-hmm.
So I go with a 7.5.
You can, yeah. 7.5 is good because they can always insert an OG tube down the tube.
Okay.
At the hospital.
All right. So I'll go with a 7.5.
Okay. So you got a 7.5, stops at 23 at the teeth. Tube has been Secured, it's confirmed by capnography, not capnometry. You've auscultated and confirmed lung sounds. And you have condensation in your tube.
Cool.
So, and that's yeah. Yep, I got all that. Okay, so they're ventilating her.
Okay. So I imagine at this point, 2 minutes have passed. So I'll have another rhythm check, another pulse check.
Still in VFib.
Still in VFib.
Mhm.
Okay. So I'll have the paramedics, firefighters continue on CPR. I am going to charge the monitor again. This time I'm going to go to 150 joules.
Okay.
Should I ask, is this a life pack or is this a soul that I'm using?
I wrote it thinking life pack in mind.
Is it? I mean, anyways, we'll go up kind of like 25, 25, 25.
AHA guidelines is go with the manufacturer's recommendation. So with life pack, it's 200, 300, 360 for defib.
Right.
So I don't know what it is for souls.
I think souls was going up 25.
But you started at the minimum requirement. So you started at 200 and you're increasing every time you shock. So you would be wrong if you just sat at like 150.
Okay.
So.
Okay, so I'm just going to continue going up 25 and 25.
Okay.
So this time I'm in 250. That's okay. What I said. Yeah.
Yes.
Yeah.
Yes.
Okay. I'm gonna begin charging. Okay. Monitors charge. Okay. Everyone clear. No one touching the patient.
Clear.
Okay. Shock delivered.
Okay.
I'm gonna ask firefighters to continue CPR.
Okay.
At this point, I will administer amiodarone.
Okay. How much?
I think initial bolus was 300 milligram. No.
Not 200.
No, I said 300.
Oh, okay. It sounded like you said 200. Yes, 300 is right.
Now I'm doubting myself. Did I say 200? Okay, let's go with
you may have said 300 on this and it sounded like 200. So, but okay. You're right with the 300.
Okay, so yeah, so now we're going with 300.
Mm-hmm.
So okay, we continue CPR. I continue monitoring the CPR. At this point, I will consider my HNTs.
Okay.
So hypoxia, patient has oxygen. Do I have to go through all of it? Do you want me, or just want to just say my HNTs and just go with the basic?
He might want us to go through it.
Yeah, I say I can remember it through my head. So it was hypoxia, it was hypovolemia. It's I don't see any bleeding on the patient, anything like that.
And you're correct in the hypovolemia with fluids.
Yeah. Hydrogen ions, patient acidosis.
Is she acidotic? I mean, you have been coding for a bit.
Yeah. At this point, she could be starting to get acidotic. So I will consider giving her sodium bicarb.
How much would you consider giving her?
Never administered sodium bicarb.
And for the record, Mr. Garrett, it's not in the cards. It's not in the card.
I'm not even sure if I'm not sure if I'm even doing right for giving sodium bicarb. Anyways.
Sodium bicarb is the correct answer to fix acidosis. Can you? So is it possible to not be acidotic after coding, for a patient to not be acidotic after coding them?
If they won't be acidotic after coding?
Yeah. Is it possible for them to not be?
I don't think so, because there's no blood moving around, so lactic acid is starting to build up.
You're correct. So they're going to be acidotic.
Okay. So yeah. So I think the dosage is 1 milliequivalent per kilogram.
Yes.
IV, I think it's over 10 minutes. Oh wait, what's this? Oh, every 10 minutes. So you give another dose, 0.5 milliequivalent every 10 minutes.
I'm not sure on the sodium bicarb.
Yeah, I'm following. So I'm just following the little booklet. So my little booklet here. So I'm just gonna go with the initial dosage of 1 milliequivalent.
Okay. Okay. So that's in.
Okay. What other H's? What's it, hypoglycemia? Hyperglycemia? What's it, sugar? I never got sugar on the patient. So I'm gonna go ahead and get a blood sugar on this patient.
Okay.
I'm gonna do it.
Blood sugar is 300.
Oh, it's 300. Okay. That is something I think we cannot fix as paramedics because we don't carry insulin.
Correct.
Yeah. So it's something to advise to the hospital.
With her now being acidotic, would you expect her blood sugar to be high?
Actually, yeah. Yeah, good point. Yeah. So yeah, she is. Yeah, she'll be. Her blood sugar will be high because she is acidotic. Yes. We give sodium bicarb. Yeah, so that should at least fix something. Or at least balance things out. Yeah. What's the other H's and T's? I think I got all my H's. So from T's, huh?
More H.
So one more H.
Has to deal with temperature.
Temperature. What's the word for that? Can't find my little booklet. You said temperature. Oh, hypothermia.
Yes.
Okay. So is patient's not below core temperature?
Yeah, if she'd been out in the cold, but she was in her home.
Yeah, so she's initial temperature was 98.2. So she's still in normal range. Yeah, so I think she's in normal range, so it's not something we need to be concerned about.
Correct.
So we'll move around. So we'll go to our T's. So of course, tension pneumothorax. So I isolated the lungs. I didn't hear any diminished sounds, even as we were doing ET tube and everything else.
Okay.
So we're clear on that. Then I think there was ischemia on that too.
Not ischemia.
No, it was.
I know what you're leaning towards, but it's not ischemia. The thing that causes ischemia?
Thrombosis.
Yeah.
Okay. So for the thrombosis, of course, that's something we can't technically identify or kind of like figure out. Of course, I think 12 leads can possibly tell us of a possible.
You can. I forgot which ones, what it shows up as for PE, but she probably has a coronary thrombosis if she had an MI. So that's pretty likely. So, I mean, what would your treatment for that be? If the artery is closed off, is there anything we can really do about it in the back of that truck?
I don't think so.
No. Your medic, your EMT can drive faster.
Diesel bolus.
Yeah. But where are you going to take this patient?
I said Helplex.
Okay. Now, why would you take them to HealthPlex versus
Doesn't
yourself?
Norman Helplex has a cath lab?
Bingo.
Yeah,
They have a cath lab.
because it's in my protocols. We either take them to Porter or Norman Helplex, depending on how close we are in our vicinity. So if we're closer to the highway that leads to Porter, then we take them to Porter.
You might as well. I don't know why you'll take an MI to Porter. You have to take them to, because it's going to take time. Like, it's going to take more time for them to arrange transport to have the patient sent over to HealthPlex than it would be for you guys to just take them straight to Plex.
I'm still trying to read their protocols, and I asked that to Robin, and she did give me an answer months ago, and I forgot for the moment. So I think if they achieve Ross, I think they'll probably take him to HealthPlex.
Okay.
I think it was that way, and then if they're still doing CPR, I think they'll take him to Porter. I might be mixing it up. I need to reread our protocols again.
But even like if we're in Wittywood and we have a STEMI, we take it straight to Plex.
Okay.
Stratford, if we have an advance down there or a medic down there and they see a STEMI, or when we do a 12 lead, if our medic is like, that's a STEMI, we go straight to Plex. We don't mess with going to Mercy Ada, which is only 25 minutes away. Dang sure ain't stopping at Purcell. So we're going to take that really long drive to Plex. Okay,
Right.
so that's
I kind of gave up. So I kind of gave up on my T's. Had to pull this thing. So I'm gonna consider for toxins. Did she overdose on anything? She didn't say she did. So
I mean, there's no signs of an overdose.
yeah. Cardiac tamponade. There was no diminished sounds around the heart.
Correct.
So we're clearing that. And then of course tension pneumothorax. We already checked that out as well.
Yeah. Okay.
So during that time, I imagine 2 minutes already have passed.
Yes. So you're asking for a rhythm check?
Yes. So get a rhythm check on the patient.
Rhythm check shows organized rhythm.
Pulse and rhythm. Pulse and rhythm.
Okay, so you see an organized rhythm on a monitor, and you have a pulse.
Pulse. Okay. At this point, I will initiate post-cardiac arrest treatments. Of course, we already had the patient intubated. Of course, we'll take another 12 lead. I'm assuming that all this cardiac arrest did happen because she has a STEMI.
She has a STEMI. What kind of STEMI did you see?
I think. Can I see the thing again?
Yep.
Okay. Just one in V1. Will it be an anterior septal infarction?
So you have.
Because I'm looking at from V1 to V4.
Is that 2? That's supposed to be 1. Okay, yeah. So you have elevation in 2, 3, and AVF, which are your what leads?
It's inferior?
Your inferior leads. And then you have reciprocal depression in your ABL, of course,
Okay.
depression in ABR. These are all depressions, but your elevation is
Yeah.
3 ABF. So yes, an inferior.
Okay.
He's
Okay.
already taken 3
Yeah.
nitro. So you were worried, you said, you're worried you couldn't give her any more nitro because it's going to reduce the preload.
Yes.
And her infarct is showing inferior, and an inferior MI affects
The inferior side of the heart.
inferior affects preload as well.
Oh, I thought you were saying location. Yeah, preload.
So that's why she went into cardiac arrest.
Yeah. I need to restudy those STEMI thing because I was reading it wrong. I was reading from V1 to V4, those depressions. So I kind of need to relearn my terms again because I was reading that thing wrong. Still, I did assume an infarction.
Yes, you were right.
Because I saw all those depressions, saw those vision. That was ding on my head. Okay, hospital now.
Yeah, you can't give a patient.
But I need to diagnose the patient properly. You can't just say an infarction and then just bring in the doctor. Oh, she has an infarction. Kind.
You can't give nitro in inferior MIs, and you cannot give it in right ventricular MIs.
Okay.
Because they both affect preload.
Mhm.
So if the preload is already reduced because of ischemia, and then you're adding nitro to it, you're going to put your patient into cardiac arrest, which you didn't. Husband did, but it's not like he knew. He has no way of knowing. He just did what the doctor told him to do. So you've got your ROSC. What are you maintaining your respirations at?
Around 10. No, look at the little pamphlet. So around 10 breaths per minute.
Okay. What do you want your SpO2 to be?
I think around 96, 98.
Mm-hmm. What your end tidal, where do you want it to be?
I think is from 35 to 4. No. 35 to 45.
Mm-hmm.
Okay.
You've already got a 12 lead. It showed that inferior MI. She's not following commands at this point. So what would you do next?
Will we initiate hypothermic treatment?
Mm-hmm.
Even though it's not kind of hard
That weird word, targeted temperature management thing.
Yeah, something trucks won't have, but hey, let's start it for the nurse.
I mean, if you have like the ice packs, if you happen to have the ones that you pop.
I think we actually have that in our service. I think I've seen them. We used to rarely use them, but we have them.
Both the hot and the cold ones. So, okay. So you are.
Okay.
You're 15. Just say you're 15 minutes from the hospital, from HealthPlex. You want to call report?
Yes. So I never done an in-call for a cardiac arrest. So I imagine you'll start and say it's a code blue.
You're going to start with your name and service.
Oh, no. Like for a cardiac arrest. So it'll still follow like normal. So this is Jesus for, no, I said the rural. I'll say McLean. From McLean Grady County EMS for patient report.
With 57-year-old female in cardiac arrest.
Yeah. So a 57-year-old female in cardiac arrest. Vital signs are, and I should have asked take vital signs again.
Okay. So your new blood pressure is 89/62. Your new pulse rate is 88. Your respirations are 10. Your SpO2 is 95%. Your blood glucose is, we'll say 180. What else do you want?
How's the cap now?
The entitle
No,
is, we'll say 40.
40. Okay. Think that's all I can get. Okay. So 35-year-old female who's in cardiac arrest, her vital signs are 80, blood pressure 82 over 6, 82, 89 over 62, heart rate is 88, SpO2 95, respiratory rates, respiratory, that's her. Yeah, respiratory is a 10, CAPNO 40. Patient was in cardiac arrest. We have achieved Ross. We started 2 IVs, 18 gauge on the right AC, 18 gauge on the left AC.
Is she tubed?
Yes, patient is also currently tubed, and we'll be at the hospital in 15 minutes.
All right, see you then.
See you then. Yeah, I never heard an ink code for cardiac arrest. I never knew how you guys will say it. Right.
I've not driven a cardiac arrest in, and I don't remember the ones that I was on. I was doing CPR, so I don't really remember what was said. I was too busy bagging with one hand and doing one-handed chest compressions all the way to Purcell Hospital with the other. So
That's tough.
yeah, that was like, yeah. All right, yeah, you're good.
Did I miss any treatment? Of course, I need to work on reading better my strips, because even though I did identify an infarction, I couldn't identify specifically what kind of infarction is, and I was reading the leads wrong. So I need to work on that.
You've pretty much got everything. Yeah, looks like you've gotten everything. You followed the algorithm. Yep.
Cool. Oh, that was wild. That was actually pretty wild. Oh boy.
Sorry.
No, you're good. I usually don't get these things. I still haven't run a cardiac arrest. All my freaking experience. I feel like I'm prepared, but I don't know how I'll react if I actually see one for the first time. So I'll be like,
I don't think it'll be that bad. Like, we've been running scenarios enough. I remember the first time that I had to do CPR. I had my CPR license for years, never had to do it until one day in Walmart, and it all kicks in. Like, it just, like that, it kicks in and you know exactly what you're supposed to do.
yeah, I'm kind of glad I took ACLS before I actually get into cardiac arrest. I feel like I feel more confident in actually dealing with one. Of course, can't say I'm fully prepared, but I feel more confident. All right.
I think you'll be great.
I'll be to my scenario. Of course, mine will be a little bit more shorter. You got this. All right. So from this time, I will say you are in McLean-Grady County EMS. So how we usually identify our ambulances are Med 1 and Med 2. You're in Med 1, and you have a paramedic partner. All right. So you have rural EMS, they're responsible for emergency and non-emergency calls. You are an ALS capable of transporting service. Of course, as I said, you have 2 paramedics. Your nearest facilities are St. Anthony Healthplex and Norman Healthplex. So Norman Healthplex will be typically for us will be 25 minutes away. Yeah, 25 minutes, and St. Anthony Helplex, incredibly close, or like around 10 minutes from the scene.
Okay.
All right. So, there you go. So, you are dispatched to a car that has pulled to the side of the hasn't pulled to the side, pulled to what we call Newcastle Gaming Center between Highway 62 and Northeast 24th Street. The caller
In the
was
parking
driving.
lot?
Yes, in the parking lot. The caller was driving the patient to an appointment, but he got sick halfway and they needed to stop. The patient complains of shortness of breath and weakness.
How old
There
is
you go.
Okay, how old is my patient?
Your patient is a 30-year-old male.
30-year-old male.
Yes.
Okay. We're in a parking lot, so I'm going to watch out very heavily for cars and
So at this time of the day, I forgot to tell you what time it is. So it is it's 7 o'clock in the morning. So you don't see too many cars in the parking lot, just a couple, 2 or 3, 5 probably around. So not too many movement around the parking lot. Just you and the firefighters that are on the scene, and your partner.
okay. So scene safety.
Mhm.
Were they in a wreck?
No.
No. Okay.
Yeah. So patient's daughter was taking the patient to see a doctor appointment. They were going northbound, Highway
Wait a minute.
62.
I have a question.
What's up?
How old is the patient?
I think I gave you the age. He was 30 years old.
30 with
Yeah.
a child old enough to drive?
Yes.
Okay. All right, just making sure.
Yeah, I think pick an age for the family member. So let's say daughter's 21 years old. No, never mind. No, yeah, that's pretty wrong. Never mind. Oh Lord. Okay, I didn't think of an age for the daughter. Every way I put it is wrong. Let's actually change the age on the father. Let's put him 50.
I mean, as long as the daughter is 16, old enough to
No,
drive.
I'm not gonna do this math in my head because the scenario started and I feel already too embarrassed about this.
So we'll keep the age because the age may affect everything else you wrote.
I sincerely apologize, Mr. Garrett. Anyways, I should have
So
thought
as
more
long
about-
as the child is at least 16 and able to drive.
Yeah, it's just
Yeah.
you asked for it. I didn't think about it. That's good.
Okay.
I failed you on that one. All right. Let's say the father is 50 years old.
Is this going to affect anything else in your scenario?
No, he's
Okay.
50 years. He's 50 years old. Daughter's 18.
Okay. Okay.
That sounds more appropriate. Okay.
So maintaining safety on the way to the car. He's sitting. You said she's driving him to an appointment. He's on the passenger side, right?
Yes.
Okay. As I'm walking up to the car, how does the patient look to me? What do I see? Does he look pale?
Patient is pale, and the patient is sitting on the passenger side, and their skin is pale and they're diaphoretic.
Okay. All right. So, because we are in a parking lot, I want to get him on the cot quickly and get him in the truck. so we're
Noted.
safer. So we have Fired help me get him onto the cot and get him in the truck. I want to go ahead and get a full set of vitals. So blood pressure, pulse, respirations, SpO2, and a finger stick, or blood glucose. Sorry, I call it finger sticks, but blood
You're good.
glucose.
So, all right, blood pressure is 84/54. His pulse is where'd it go? Sorry, my document just went blank. Is 180 rapid and weak. Respirations are 20, but they're labored. SpO2 is an 80%. And the blood sugar is 10.
Oh, his blood sugar is 10. Okay, so we're gonna go ahead and put him on 15 liters non-rebreather to fix his
Cool.
oxygen.
All right, oxygen went up to 96. It's still climbing. Still climbing, of course.
Alrighty. While I'm getting 2 IVs on this guy, I'm going to attempt to get 2 large bore IVs on him. I'm gonna direct my EMT to go ahead or get one of the firefighters go ahead and put him on a full 12 lead.
You
And
didn't
as
just to remind you, your partner is a paramedic.
oh yes, it's paramedic. That's right.
Yeah.
Okay. Well, if we're both paramedics, we're both going to get an arm, and we're both going to get these 18 gauge IVs
Okay.
in the ACs. So we've got those taken care of. I'll go ahead and get fluids running. I need to get a quick history from the daughter while we're doing this. Is he allergic to any medications?
Not that any that she knows of.
Okay, not known. Does he take any medications?
Yes, she struggles to pronounce it. She goes, I'll go get something that says metformin.
Okay, metformin. And we've got our IVs in, so we're going to go ahead and push some D50 on him.
Right.
I'm going to push it slow and easy, and I'm going to keep checking the site to check for extravasation, because it's really acidic and it's going to break down the skin. And it's going to take some time to push it in, but after I push it all in, I'm going to flush the line really good with saline. So
is there anything else you want to do for this patient?
Yes, in just a second. I just want to make sure. What other medications? Is that the only one?
Yes, the only one that she knows, because he found the bottle with him.
Okay. Does she know what other diseases he has, since he's obviously?
She knows that he's diabetic. She doesn't know what type.
Okay. And no heart issues or anything else?
Nope, not that she knows.
Okay. So we've got, it's not TK, because his blood sugar was 10. So we're pushing not the metformin, the D50. We've got our 12 lead on. I have my partner look at that real quick at the 12 lead. What do I have?
It seems not unremarkable 12 leads, but you notice that he's in sinus tach. To be more specifically, unstable tach.
Right. sure I don't miss anything on here. So we've already got 12 lead on. We've got air, we've got oxygen going. We've got our IV access. We're going to go ahead and synchronize cardiovert. So we're going to add the pads
Noted.
and hold on. Stable gets medication, unstable gets electricity. Blood pressure. Yes. Okay. So yes, we're going to synchronize cardiovert. Try not to make the same mistake I made one day.
All right.
So got the pads on. I'm go ahead and press the get a picture of the life pack before, make sure I'm doing this right. Yes, the sync button. It is the sync button. You go ahead and press the sync button. And I'm going to look for the triangles to be on every QRS. Once I see that it's synced, I'm going to press and hold the charge. Well, I'm going to charge, it's going to charge. And then I'm gonna press and hold because that one's the one you press and hold until,
Okay.
and it's, I have to start out at 100 joules.
Yeah.
Because you start low.
Yep.
Yes.
Correct. All right.
Okay.
So have you administered the shock?
And holding the button down to deliver the shock.
All right.
Delivers the shock. And what do I see on the monitor?
All right. You see on the monitor, it's ventricular. You got VFib going now. Patient went completely unresponsive.
Okay. So now we are going to switch to our cardiac arrest protocol.
Hey, it's the part that we went through, and it's the part Mr. Garrett really wants to try. So let's do it. And you got to retest your ACLS. So let's go.
Okay. So VFib is a shockable rhythm. We've already got the pads on. So I'm going to go ahead and charge up the monitor for a shock.
Have you begun CPR?
It's witnessed. So I'm gonna go ahead and deliver that shock we're gonna start at 200 joules and we're gonna immediately go into CPR once the shock has been delivered. We've already got our IV access. Now I've switched. So one of the firefighters is doing compressions at a rate of 100 to 120 a minute.
You did shock, right?
We did shock.
Okay, so just I didn't tell you the rhythm. So the rhythm is still VFib. It's still VFib.
Okay.
So you can you start CPR. Okay, you can continue.
I'm gonna have the other firefighter get a BVM and connect it to high flow oxygen and put it on this patient and start bagging. I want to see good chest rise and fall.
Okay.
So after 2 minutes, we're going to do a rhythm check and a pulse check. And what do I have?
Still pulseless. Did you shock on this one, or you're just doing a rhythm check?
We're just doing a rhythm check.
Okay, yeah, he's still, because of course he's still in VFib and it still doesn't have a pulse.
Okay. So we're gonna shock again.
Okay.
This time we're gonna go to 300 joules. And everybody's clear.
It's clear.
It's charged. It's ready to deliver shock. Everybody's clear. Going to deliver shock now. And
all right.
Immediately they're going to start chest compressions.
Cool.
And bagging again.
All right. So after shocking the patient, you notice there seems to appear normal. Rhythm?
Do I have a femoral pulse?
No.
No femoral pulse. So now I'm in PEA. My
Nice.
favorites. My favorites. So I'm going to go ahead and draw. Go ahead and push 1 milligram of 1 to 10,000 epi IV. And I'm going to go ahead and consider an advanced airway at this point.
All right.
How big is my patient?
Your patient's 180 pounds.
It's 180 pounds. So roughly 82 kgs. Okay. So we've given epi. We're going to go ahead and drop an ET tube. I'm going to attempt a 7.5. Approximately, we'll say 22 at the teeth. The airway was clear. It was
Yeah, every was clear.
okay. Get that in, and I see condensation in the tube. I'm going to check with my stethoscope and listen for lung sounds. Do I hear lung sounds on both sides?
Yep, you hear it clearly. When you check your epigastric, you hear no sound in the stomach.
Okay, so no gastric distension. So, and then I'm gonna connect CAPNO on.
Okay.
So we have CAPNO confirmation.
Yep, your CAPNO is around 15.
Okay. CAPNO is 15. All right, so I'm gonna direct firefighter to connect the BVM to the tube if he hadn't already. Hopefully he already knows what he's supposed to do. And he's going to continue giving one breath every 5 to 6 seconds. This point, we're going to pause and do a rhythm check and pulse check.
Oh.
What do I have?
Yep, so patient is still in PEA.
Still PEA.
Yep.
All right, so we're going to continue CPR. Look at my HSNTs. So we're treating hypoxia with high flow oxygen and good ventilations. We're treating hypovolemia. We've got, I don't think I ever said it.
No, I think
Okay.
you didn't hang fluid.
We're going to hang normal saline wide open.
Noted.
What at this point we could recheck a blood sugar, but they may be in acidosis, so I'd consider sodium bicarb 1 milliequivalent per kg. So that's 80.
Yeah, after giving the DFib, but the D50, but even though patient did went cardiac arrest, their blood sugar came out as 250.
Okay, so finger stick is 250.
Yeah, 250.
Okay. Do I see any signs of hypokalemia or hyperkalemia on my monitor?
No,
No PT waves or anything?
No, your thing is
short. Oh, we haven't, that's right.
Your QR.
So I can't, until I do a 12 lead, I can't.
Yeah, QR's complex is narrow, doesn't seem to be wide.
Okay. Patient wasn't in the cold for extended periods of time, so I don't think I have to rule out hypothermia. We've been doing chest compressions for a while, so I'm gonna go ahead and recheck my lung sounds and make sure that we haven't caused a tension pneumo. Do I have lung sounds on both sides?
No diminished sounds.
Huh?
No diminished sounds.
Okay, no diminished sounds. Good. Do I have good heart sounds?
Yes.
Okay. No JVD and tracheal deviation, right?
Nope.
Okay, so tamponade and pneumos ruled out. Toxins, does he have pinpoint pupils when I check his pupils?
Nope.
No? Okay. And then if there's a PE, when I was listening to his chest and everything, did I notice signs of a PE, like it being purple all the way up?
No.
No? Okay, so I can't definitively say he doesn't have PE, but at this moment, I don't see anything for that. He could have a coronary thrombosis. My best bet would get him to, does St. Anthony's Health Flex have a cath lab?
No, this is the South one, like the South Helplex thing.
Okay, all right.
Yeah.
So
For us,
we're
we never
gonna
sent- we
go
never sent them
to
there.
Norman Health Flex because they do have a cath lab.
All right.
So my HSNTs are taken care of. We're going to do another rhythm and pulse check. What do I have?
So you palpated and you start to feel a pulse. The pulse matches the rhythm that is on the monitor,
Okay. so
and you
do-
notice a increase on capno, exploded around like 60 and now dropping.
Okay. All right. So now we're going to switch to our ROSC algorithm. We've already got our airway managed. I'm going to make sure that the person who is bagging is giving 10 breaths a minute. So that's, I think it's like 5 breaths or 5 seconds. Every 5 seconds, give a breath is what I'm trying to say. SpO2, we want to keep at 92 to 98%. In tidal, I want to keep between 35 and 45 millimeters of mercury. What's the other one? Oh, the systolic. Now that I have ROSC, can I get a blood pressure, please?
Blood pressure now. I'm trying to see what was the old one. Oh yeah. So blood pressure now is 98 over 72.
Okay. So I'd like it to be closer to 100. How am I on my fluids? Or have all of my fluids gone in yet?
No.
No? Okay.
There's
I mean, we're pretty
there's-
close to 100. I just want to really keep it. We're supposed to keep it above 90 for systolic. So we are technically doing good on that. Get a new 12 lead. And
12 so unremarkable, but it's normal.
okay.
Between average. Forgot what's the proper term for it.
Okay. So we're headed to a cath lab. So sometimes blockages don't show up on EKG, but when they cath them, they'll find them. And also may show up in his blood work, which I can't do. Is the patient following commands?
No.
Okay. We will attempt targeted temperature management with ice packs if we have them on the truck. I'm going to place those behind the neck, in the armpits, and in the groin area. I'm going to keep reassessing my patient every couple minutes, checking to make sure that the person doing compressions and the person bagging are swapping every couple of cycles so they don't get fatigued. Making sure that what am I talking about? We've just got the guy bagging. They can swap bagging. If she's still not following commands, is she bucking or is he bucking the tube?
No.
No. Okay. So I don't have to consider any sedation at this point. This is all okay. So I'll just see if they need to swap bagging. Report. I need to call report. How far out from the hospital are we?
Let's say now you are after all that, you'll probably be 15 minutes away.
Okay, 15 minutes out,
Actually, no, you know what? Let's say 10 minutes. You're 10 minutes away.
10 minutes out.
Mhm.
Okay. Go ahead and call in report. This is Caroline with McLean Grady coming in with cardiac arrest with ROSC. We have 2 bilateral 18 gauge IVs in both ACs. We have the patient is intubated without sedation. What else do we have? We've got 1,000 liter, or not 1,000 liter, 1,000 cc bag of
That's a lot
normal
of fluid.
saline running. At this moment, the patient's vitals are blood pressure's 98/72. Their pulse is, what is the new pulse? I forgot to ask about that.
62.
Pulse is 62. Respirations are 10. My SpO2 is, we'll say 95%.
Oh, sorry. 97.
97%. And what is my end tidal right now?
Your end tidal is sitting at 40.
Okay. Let me repeat that report. It's McLean Grady. It's Caroline with McLean Grady coming in with a cardiac arrest with ROSC. The patient, we have 2 large bore IVs in both ACs. Patient is intubated without sedation. Current vitals are 98/72 for blood pressure, 62 pulse, respirations 10, SpO2 is 97%. End tidal is 40, and the last blood glucose was 250. Am I missing anything else? Not that I can think of. Everything else I'm gonna have to give and report in the room.
Yep, you're good.
We'll see you when I get there. We're about 10 minutes away.
All right. So you were going with pulmonary embolism on this patient, right?
On this one?
Yeah.
No, I was
said you were
thinking
saying-
this was a D50 wake up that became a cardiac arrest because their blood
Yeah.
sugar tank's so low.
Yep, good job. Yeah. Cardiac
Okay.
arrest, hypoglycemia induced cardiac arrest.
Oh,
I know it went wild. Usually I was expecting you to probably give the D50 kind of like at the end, and that would have been like what will solve the issue. But I still went through all that. But hey, you thought fast. So in real life, you probably might. I got him out of this. Who knows?
yeah. When you said pale diaphoretic, blood pressure was 84/54, and I'm like, and you said pulse is 180. I was like, oh, okay. So they're probably like an SVT. Like, what's just I was just joking around. Like, what's their blood sugar? 10. What?
Yeah. A lot of people don't ask about blood sugars. That's why I kind of like playing around with them, because some people just don't want to take blood sugars. And it's like, my man, take blood sugar. Sometimes it could be blood sugar that could save everything and get you out of this stupid mess.
Yep.
Yeah.
Okay, I'm gonna go ahead and pause the recording if you're okay with that.
Yep.
Or stop the recording. Stop the recording.